All right, so good afternoon. You all have copies of my slides, so I'm gonna hit really kind of the high points, answer a couple questions that have come through as I've been sitting in the audience and kind of answer those. But I set my slides up really kind of looking at the questions that were proposed by the staff here as to what are some of the specific insights that you're looking for. So one of the things about our practice is that we are what's called in our industry a cash-only practice. We don't do any direct billing to any insurances or PBMs for any compounded medications. So it is kind of basically a kind of a fee for service. Any of the patients that we work with, they're going to be paying cash out of pocket. And like was mentioned before, sometimes these medications can run up in price pretty high pretty quick. And so that kind of touches back into a point that I'd like to make. For our compounding for pain, from what you've heard from the other panelists here, soft tissue injuries, chronic pain, and hospice care are kind of our three main areas that we work with when we're working with pain. For common formulations, we really don't have any set starting point. And we don't have any one formulation that's really overwhelmingly used more than another. Everything that we really do, especially in regards to pain management, is very patient specific. It's based on the patient's need, what the prescriber is wanting to treat. And that is really kind of, I hope, the overall theme that you take out of this panel is that we're working individually with these patients one-on-one, with the patient, with the prescriber to bring up or figure out the best formulation to treat that patient's pain. And so when we talk about items that are like FDA approved and how they're going to penetrate skin and where the studies are, I look at diclofenac gel that's used for arthritis, either in the lower or the upper extremities. When the prescriber will give that prescription to the patient, they're going to walk into a pharmacy, the pharmacist is going to fill it, give it to the patient, and it's done. There's going to be some patient counseling, but it's not going to be anything out of the norm of what a patient would be counseled on an oral medication or anything like that. We are much more hands-on when we're dealing with these patients. We're usually talking with the patient 3 to 4 times before the formulation is even started. We're talking with the prescriber at least once or twice before we start this process. So this whole thing is very, very hands-on. It's really outside the realm of how I think most everybody on the panel is going to interact with a pharmacist on a day-to-day basis. When we jump into this line of work and this profession of compounding, we know that we're going to be doing a lot more patient care than what we would typically see at a regular pharmacy. We've talked about the indications, information shared with patients and regarding a use. When we're asked for a recommendation, our MO is that we're going to start with the lowest strength with the least amount of ingredients that we possibly can that's going to be clinically relevant to what the patient and the prescriber are looking to treat. So we basically have kind of what we call is start low and go slow. If it's an inflammatory issue, we're going to start off with a non-steroidal anti-inflammatory and start with that at a lower strength and maybe add in other ingredients as we go along, depending on patient response and how they do with the medication, if there's any side effects, et cetera. How do we get the prescriptions? We heard about these fax forms that are going out, these marketing forms. For what we do for our marketing, we go out to our physicians in our trade area and we talk to them about the services that we provide. We rarely employ these types of materials to our prescribers, and we do not 100% do that for pain medications. We want the prescribers to approach us with the individual patient cases that they are having issues with and have that discussion with them. We don't want them just checking boxes as saying, I want this, I want this, I want this. We want to have that discussion to make sure that the treatment that's being approved or being prescribed is clinically appropriate. And that kind of brings me to one thing that's not on this slide that was brought up on this panel or brought up in this group earlier is where does the liability reside for these medications once they're prescribed? And it's shared both by the pharmacist and by the prescriber. But in the end, the pharmacist is always that last line of defense to protect against patient harm. So if we had to split what this liability is, it's probably kind of 60-40 on the pharmacist versus the prescriber. But we share that liability. We share that responsibility. And so we want to make sure in my practice and what we're doing as a staff to protect ourselves from that liability, number one, but we want to make sure that we're providing the best possible outcome for that patient every single time. Do we recommend or does the prescriber specify ingredients? Again, really depends on the patient. We have some prescribers in our area that are very well versed in the use of topical pain medications. Some aren't, but again, we're back to that situation, having that conversation before we even start compounding that product for that patient. We want to have that, that input as to what's going to be used for that patient. For the trends that we've fulfilled on prescriptions over these last 10 to 15 years, we've been pretty steady. And it's been mentioned here before that we've gone through a bit of a rough patch in our industry where we saw an explosion of pain creams being prescribed across the United States. And I would hazard a guess that's probably one of the reasons FDA asked you to start conducting these meetings. Those need to be understood as those were fraudulent, they were illegal. The pharmacies that were providing these medications are being prosecuted as they should. We've never partaken in that. We've never filed under any insurances. We've never done any third parties or worked with TRICARE or any of the other federal programs that are out there. So our trend has been pretty steady. You know, we're not going to see a great explosion of what we've done over the last 20 years. Information regarding dermal penetration, we've talked about that ad nauseum. We've got great published literature both in several journals that are available to compounding pharmacies, but also by the companies that we purchase our APIs, our bases from. They do a lot of great studies that they have on hand that can talk about what we can do with these types of medications. And the amount applied per application, covered that. The only thing that we do maybe just a little bit different is if we see something that's going to be of high risk of overdose or abuse, especially in hospice care, when we're talking about possibly doing transdermal morphines or other opioids, we will tend to unit dose those medications in the nursing home setting or in the hospice care setting to make sure that we stay away from that possibility of overdose and limit the ability of any of the abuse potential for them. So we've talked about a lot of these different things. What the patient population that we see that come to us for treatment, these are patients that are not coming to us to use compounded pain medications as a first-line therapy. And most of the times it's not secondary, tertiary. We get patients that have been either split into two different categories. One, they've tried 5, 6, 7 different medications and have struggled mightily to get their pain under control. The other type of patient population we'll typically see is that they have a lot of other medications that they're taking that make oral medications contraindicated for them, and the prescriber's looking at us for some input on that. Even in that patient population, they've tried 1 or 2 medications, and I've got a quick case study to show where that kind of falls into play and how that works. But overall, the biggest part of this is that these medications, they need to be implemented, they need to be prescribed, and then they need to be used by the patient. And all of this needs to be done in close consultation between the patient, the pharmacist, and the prescriber. Close monitoring of dose response, any side effects that occur, those are important tools in making sure that these therapies are implemented correctly and serve of the most benefit to the patients. So 2 quick, I'm going to call them case studies in quotation marks because they're not full-blown case studies, but we did have one patient we started working with right after our pharmacy was established. He was injured in the late 70s and had chronic pain in both feet. He was treated over 2 decades with opioids and gabapentin to control the pain. Obviously, over that time period, opioids had been escalated over the years. We were approached in early 2000. We started the patient on a ketoprofen topical. And over that time period, he's increased and added amitriptyline and increased the ketoprofen formulation. Since 2010, patient has been pain-free and no longer taking oral opioids or gabapentin. He is strictly just on this topical pain medication, and it is controlling his pain. This is an odd case for us. This is actually a workers' comp case, and we work through his case manager. This is obviously a long-term injury for this patient. We worked through with his case manager in the early 2000s, in 2003 or 2004, and worked with the workers' comp to get this typical prescription covered by that. But that's a rarity. We only have 2 patients right now that are under workers' comp. The second patient is a 92-year-old male. He's suffered from several microfractures in his lower lumbar secondary to a fall. All oral opioids, all of them, cause severe disorientation and hallucinations. And oral NSAIDs were contraindicated with his current oral therapy. The only thing that controlled his pain was to take 2 to 3 grams of Tylenol every 24 hours. And I think we can all agree in this patient population, not even knowing the other medications that he was on, that's not a great long-term solution for him. So we started the patient on a 2% gabapentin. We did go a little high on the ketoprofen than what we normally do with 20%, but we were really trying to make sure that we got him off of that high dose of Tylenol as quickly as possible. So this required even more than what we normally do. We did close monitoring with this patient weekly by the prescriber, daily or every other day by the pharmacy staff to monitor for any adverse effects or drug interactions. And only after 2 days of topical therapy, he ceased the use of his Tylenol as the pain was now tolerable. 3 weeks later, he was able to resume his physical therapy, and now he's on a little bit higher strength of gabapentin and lidocaine with no side effects or drug interactions occurring with him. So with that, I will pass it along.